Good evening to everyone, or good morning, depends from which part of the world you're following us. I thank you very much for being here, for joining this IARC webinar on social inequalities and cancer. As Sandrine said, I'm Dr. Salvatore Vaccarella, scientist at the Cancer Surveillance section at the IARC, and I will be chairing this event. And it's a real pleasure for me and for IARC to have three internationally renowned speakers with a wide experience on this topic. Next slide, please. The three speakers are Professor Diana Sarfati, Dr. Isabel Sojamataran, and Dr. Ahmedin Jamal. Each of them will speak for about 12-13 minutes. And as Sandrine said, during the talk or after the talk, you can pose your questions through the chat box. And at the end of the three talks, the speakers will try to address these questions. Next one, please. So our guests will lead us through what is currently known about the evidence of social inequalities on cancer, and they will also provide specific examples from different areas in the world. And also importantly, they will give us hints and they will discuss the possible solutions that are available to reduce social inequalities in cancer. Next one, please. So before leaving the floor to these three speakers, I will provide some context on the topic, and I'll present a couple of slides based on some results that are shown in the World Cancer Report. There is a large section in this book about social inequalities and cancer, and also results that are also published in part on the IARC scientific publication on social inequalities in cancer that was recently published last year. And so the slides refer to Europe and shows this slide shows major inequalities in the sense of differences in cancer mortality across educational levels. And this is true in all the countries considered here in Europe. We see that in each country, low educated have higher or a much higher sometimes probability of dying from cancer compared to their more highly educated fellow citizens. So this kind of pattern is seen all over the world, not only in Europe, it's seen in many other countries when the data are available. Lack of availability of data is one of the problems in this field, and is also a priority. We will see later, probably with Diana. Another interesting thing to which this slide is pointing is the fact that these inequalities in cancer mortality are higher in some countries compared to others. For instance, on the right side, countries on the right side of this figure have higher inequalities in cancer mortality compared to those on the left. So this means that some countries that do better than others in limiting, not in eliminating, but in limiting educational inequalities in mortality. Next slide, please, Sandrine. This other slide shows that also, in addition, social inequalities in cancer mortality affect the large majority of the cancer types, although possibly with a different intensity across different organs. The infographics here shows that educational inequalities are stronger for tobacco-related cancers and for cancers such as stomach and liver. This is the situation in men. Next slide, please, Sandrine. And the situation in women is pretty much the same, with the addition of cervical cancer, which is one of the cancers with a very strong social gradient for mortality. So in short, before leaving the floor to the speakers, social inequalities in cancer affect all citizens, all social groups in all countries, and have an impact on most cancer types. Now, I'm very glad to leave the floor to Diana Sarfati, Professor Diana Sarfati. She is a Chief Executive of the TECAO, the National Cancer Control Agency of New Zealand, and she is responsible for providing advice on cancer control to the New Zealand government and for demonstrating progress in relation to cancer control activities in the country and for bridging a commitment to improving equity. She is also professor of the University of Otago and director of the Cancer and Chronic Condition Research Group. She has led a large body of research in relation to disparities and cancer outcomes, which have resulted in the identification of key patient and health system factors that influence cancer survival. Importantly, this work has been used extensively by health policymakers, clinicians, and other researchers to develop policies and practices that aim to reduce social inequalities in cancer. And today she's going to talk about what are social inequalities in cancer and what we can do about them. Diana, whenever you're ready, the floor is yours.
Thank you so much, Salvatore. And good morning, good evening, good afternoon, everybody. Thank you so much for inviting me to come and speak today about this important topic. So as the chair has mentioned, I've been asked to talk today about what are social inequalities, what do we mean by that term in relation to cancer, and in general and in high-level terms, what can we do about them? So what are social inequalities? First of all, just to identify the differences in the terms inequality compared with inequity. So inequality really just means that there are differences between groups. That's a relatively straightforward concept. Inequity is used when those differences are deemed to be in some way unfair or stemming from injustice. And injustice can be in any kind of context, but it might be, for example, uneven access to healthcare. So often in this presentation or this webinar, we'll be using the term inequality. Inequity is a subset of that, but we're particularly interested in inequalities which are amenable to action. So social inequalities are differences according to social group, and that can really be any social group. But most commonly when we talk about social inequalities, we're really focusing on these first two categories here. So socioeconomic inequalities, and those are measured income, deprivation, education, occupation, when we're thinking about individuals, those kinds of measures. And the other big one is race or ethnicity. But you can see there's a whole range of other kind of social factors that are relevant and where social inequalities exist. So social inequalities in cancer incidence and outcomes occur both between countries and within countries. And today, both of those will be highlighted. So the next speaker will be talking mainly about between country differences, whereas both myself and the final speaker will be talking more about those that occur between groups within countries. But one of the interesting things is that the drivers, particularly the proximal drivers of those differences, both between countries and within countries, are quite similar. And they are, first of all, differences between groups, whether they're individuals within countries or social groups within countries or between countries, differences between those groups in terms of determinants of health. And that includes things like access to power and resources, or an exposure to things that lead to disease. There are also differences between groups in terms of access to healthcare. So that's an important driver of inequalities and inequities. And finally, differences between groups in the quality of care received. So it's not just that care is received, but that the quality of the care is similar between groups. Now, I sort of apologize for this slide a little bit because it's basically showing off that over here in New Zealand, we're in the middle of summer. I've just got back from a 4-week summer holiday, and these were some photos taken from the last 4 weeks. But it's really just to remind me to tell you that New Zealand is a country of just over 5 million people. About 15% of the population in New Zealand self-identify as Maori, and that's the indigenous population of New Zealand. And like in many countries in the world, indigenous populations tend to suffer from poorer health than the non-indigenous usually majority in those countries, and that's true in New Zealand. So in relation to cancer, here are the top 10 most common cancers among Māori in New Zealand. And it compares the incidence of those cancers for Māori compared with non-Māori. So you've got Māori in the blue there, non-Māori in white. And you can see the gap between the two. And you can see the really big gaps, particularly if you focus in on lung cancer, there are very big gaps there, but also for breast cancer, in relative terms, stomach and liver cancer, there are major inequalities there, also uterine pancreatic cancer. So for many cancers, Māori have higher incidence. And you can see that sort of summarised in this slide here, with the blue bars extending to the right showing the extent to which there are absolute greater rates of cancers for Māori, and the white bars extending to the left show where that's the case for non-Māori. And there are some cancers where non-Māori have higher rates, but predominantly it's the Indigenous population that have high rates of cancers. And the three key drivers for those inequities, where inequities exist for those cancers in New Zealand, are these three. The first, tobacco; the second, infection; and the third, obesity. And again, these three proximal drivers are reflected in international patterns in cancer incidence as well. So they're drivers of both inequalities within countries and inequalities between countries. But the other really important thing to note is that whilst these are the proximal drivers, so these are the immediate risk factors for cancers, they reflect higher level determinants of health. And just to sort of explain how that works, I'm just going to use the example of infection. So if we focus in on stomach cancer in New Zealand, this is now mortality rates, and you can see that the mortality rates for Māori in blue there are several times higher than the mortality rates for stomach cancer for the rest of the population in New Zealand. So one might ask ourselves, what causes stomach cancer, which therefore could be driving these inequalities? So what causes stomach cancer? An answer to that question would be Helicobacter pylori, H. pylori. So Helicobacter pylori is a chronic infection, a bacterial infection, which typically people are infected early in life. It tends to stay around in the lining of the stomach and can cause stomach cancer. It's a relatively common infection. The vast majority of people infected with Helicobacter pylori do not go on to get stomach cancer. But it's also true to say that 90% of distal stomach cancers are caused by H. pylori. So distal stomach cancers are those in the further away part of the stomach, further away from the food pipe. So we know that in New Zealand, Māori and Pacific people and people living in more deprived areas are more likely to be infected with H. pylori. But why is that? And the answer to that is childhood poverty and overcrowding. So childhood poverty and overcrowding is the key risk factor for H. pylori infection in the context of high-income countries and in New Zealand. But then the question that follows from that is, why is it that Māori would have high levels of childhood poverty and overcrowding? And then we get into these much higher level determinants. So things like economic policies over time, historical trauma, employment policies, institutional racism. So when we're thinking about inequalities and inequities in cancer incidence, we need to be thinking right along that whole continuum of causation. So it's also true to say childhood poverty causes stomach cancer, and even historical trauma can cause stomach cancer through this mechanism. And again, interestingly, those sorts of factors play out in an international level as well. And Dr. Isabel will be talking more about this shortly. But just as an example, this slide shows the proportion of cancers that are caused by infection across countries across the world. And what you can see there is high-income countries tend to have a lower proportion of cancers caused by infection. And similarly, if you look at H. pylori prevalence by region, you can see the regions at the top of the graph there, which are predominantly regions with high-income countries, have lower proportion of, lower prevalence of H. pylori. So again, those same sort of patterns playing out internationally as you see within a country. Right, so I'm going to move now from inequalities in cancer incidence, so that's about who gets cancer, to inequalities in cancer survival. And again, I'm going to focus in on examples from New Zealand, but the same sort of factors play out in other countries around the world. So this is just an illustration of the issue relating to cancer survival inequalities. So what you can see here is a whole range of cancer sites. The greyish horizontal line in the middle is the point at which if Māori and non-Māori had the same survival experience, all the blue bars would be sitting along that horizontal grey line. The extent to which the blue bars extend to the right of that line show the extent to which Māori have poorer cancer survival than non-Māori. The extent to which the blue bars extend the opposite way to the left show the extent to which non-Māori have poorer survival. And you can see that hardly ever happens. There's one minor example at the bottom there. Otherwise, in all cancer sites, Māori patients have poorer cancer survival once diagnosed than non-Māori. And this is in the context of New Zealand, which has universal health care and all secondary care services are free at the point of use. So why? What are the drivers of inequalities in cancer survival? Now there's a lot of detail on the slide. Don't worry about the detail. Really to highlight here that there are two sets of factors that are important here. There are patient factors and health system factors. But evidence shows that by and large, it's the health system factors that are most important in driving inequalities in cancer survival. So those are things like access to early detection, availability of quality treatment, affordability of quality treatment, and acceptability of that treatment. And all of those things sit in this broader context again of the economic, political, and social context in which people live. So just moving on to in general, how do we address inequalities in cancer incidence and outcomes? So first of all, we do have to be mindful of those broad overarching factors. So we need to be thinking about, as countries or as communities, identifying and rectifying the social, economic and political structural barriers which hinder well-being for some social groups. For cancer specifically, we need to be thinking about national or regional comprehensive cancer policies, frameworks and strategies which identify achieving equity as a primary goal. So that has to be a primary goal of those strategies. If there's not buy-in at that level, it's going to be very difficult to move the agenda forward. And then within those policies, frameworks and strategies, the three broad areas that need focus is, first of all, improved data systems and research. And the chair mentioned this in his introduction. So this again is both within countries and between countries. So we need to have excellent cancer surveillance, and we need to have excellent monitoring and reporting on progress, and that requires data. So in some low and middle income countries, for example, there are major issues with collecting those data, but there are also issues with collecting those data for some poorly served social groups within countries, and Indigenous populations are an example where data are often poor. We need to focus on reducing incidence, and addressing this issue is really where we're going to get the major bang for buck. So this is stopping people getting cancer in the first place. So we need to have strategies to address determinants. We need to make sure that the cost-effective prevention interventions have been implemented. So these are things like ensuring access to immunisation against HPV and hepatitis B virus, for example, ensuring access to cost-effective cancer screening for cervical cancer where that is feasible, and ensuring environments support healthy lifestyles. And then finally, excellent healthcare. That's the final area of focus to achieve equity. So this refers to universal healthcare, a health and research workforce that reflects the community it serves. So within countries, that the health and research workforce include those who are most affected by inequalities, and also, of course, access to high quality screening, diagnostic and treatment for cancer. So my final slide really reiterates those points that I've just made, but just to summarize, how do we make a difference? We need a stated commitment from the very top to achieving equity. We need healthcare leadership that includes those most affected by inequality. So in the context of New Zealand, Māori leadership to provide guidance on how we address the factors that are inhibiting our ability to achieve equity. We need strategies and policies both within and outside the health sector to address root causes of inequality. That includes unequal access to power and resources, cost-effective strategies aimed at preventing cancer, health system organisation with processes and systems to ensure equal access to and through health services, with each step considered from an equity perspective, because inequity can be introduced at every step along the pathway, and a health workforce that reflects the community it serves and is culturally competent. And finally, we need data, good data collection, excellent data, excellent analysis, and excellent reporting and monitoring. So thank you very much, and I will hand back to the chair.
Thank you very much, Diana. Thank you very much for this nice overview and to provide some evidence from New Zealand and some experience, the experience you had in your country. The next speaker is Isabel Sojamataran. She's Deputy Section Head of the Section of Cancer Surveillance in IARC. She's a medical epidemiologist with a special interest in cancer prevention. She has received a medical degree from the University of Indonesia in 2001 and a PhD in cancer epidemiology at the Erasmus MC in Rotterdam. She has worked at the Harvard School of Public Health on global indicators of cancer burden, and she took a position here in IARC in 2011, where she is currently assessing international variation of cancer burden and also the role of various risk factors on cancer burden. And now she's going to talk about socioeconomic inequalities and cancer incidence, quantifying the role of major risk factors. Isabel, the floor is yours when you're ready.
Okay, thank you so much for that introduction, and thank you again for everybody who is here. It's a rare occasion that we can be in the same moment with Diana, Ahmedin, and Salvatore, but also with everybody who are joining from every part of the world. So it's a pleasure to be here. So picking up on Diana's now presentation, which is really wonderful because then it made a good introduction to this next talk. I will be focusing on the role of major risk factors. So I'll pick up even only one risk factor, but it really applies to all other risk factors. Diana put an example of an infection. Today I'll put the example of tobacco smoking. And then what I'll also then bring up is then a measure or an indicator which is called population attributable fraction. It was already used as well previously, but then I'll then go along slowly to go through a few examples, and I hope it also then made the point on how socioeconomic inequality in cancer incidence and part of it are then explained by these differences in major risk factors for cancer. So I think a lot of us here are cancer experts who are listening to this webinar. So there, we know there are really the known cancer risk factors. Just to name a few, it's listed here in the European Code Against Cancer. They might be a bit different in terms of ranking in different countries. But this is then an example from the United States, picking up then from where Ahmedin is working. They're somewhat similar. There's then tobacco smoking, healthier lifestyle, mentioned then already a few examples, obesity, etc. safe in the sun, so sun exposure, but also then some infectious agents. Helicobacter was mentioned before, HPV is then another example here, but also then other factors that can determine then risk of cancer, but also then important for at the end cancer outcome. I'll focus again then on one risk factor that is explaining really one large proportion of cancer overall globally, still the most important part, which is tobacco smoking. So this is then an example that is taken from a survey in 2019, so very recent data in the UK. In the UK probably is one of the first countries in the world that brought up social injustice in the Black Report. And this is just to show how different tobacco smoking still today, after many, many decades of putting this out as a part of the national plans, that still today tobacco smoking differs by educational level. So if we're looking into the highest degree, people with the highest education, they have then less than 10% among those group are smoker. If you see then a bit with the higher education, somewhat a bit more, 12% there. But then if there's, for example, going then through the socioeconomic, the educational level, more and more people are current smoker in the UK. And then they collected the data. You see already then different measures of socioeconomic differences. So this is then by educational level. They also then showed, for example, by type of occupation also, those who are then taking the position of managerial or professional occupations, again, they have much lower tobacco smoking prevalence or current smokers among those groups. For example, here as compared to the routine and manual one. You may then notice, for example, never worked, have somewhat lower than to that. It's because it's a very mixed group. Often people who are who never work actually then have some income from somewhere else, meaning that they're actually probably not of that lower socioeconomic status. And this is true. They also have data by employment status, etc., etc. You see exactly the same pattern as you can see here. So we know then risk factors or prevalence of major cancer risk factors different by socioeconomic groups. What I'll show you then, how we can then estimate how that differences actually impact then differences in cancer risk or cancer incidence. So what I'll use then a measure which is called population attributable fraction. A lot of you have heard about it. Diana just used it before. So this is then the proportion of cases or death that can be attributed or that can be caused to a certain factor. So for example, you must have heard that 40% of all cancer are caused by major risk factors. This 40% is what the population attributable fraction. Why do you want to use this, or people are interested in this? It's interesting for two reasons. It's easy to use. It's easily understandable by public in scientific environment, but also lay public. So it's an easy measure to communicate to public. It's easy then to use it as well to encourage at the end individual changes. In terms of the public, it's an easy number, but it's also an easy number for policy makings. Using then the number that's available, if you do it correctly in terms of estimating this population attributable fraction, it also can be used to guide policy making because then it gives a sense of priorities, which risk factors may be then more important as compared to others. So that's why then population attributable fraction is quite interesting to use in different areas. How it is calculated, it can be calculated in different ways depending on the data that you have. But today what I'm going to use is then the simple calculation that's done by suggested by Levin. It uses available data from the population and aggregated level. So first you need then to have the risk factors prevalence. So how many people are smokers, for example, like the data that I showed before. You need to also then have data on the relationship between that risk factor and a type of cancer. And finally, then of course, you need then the cancer incidence itself. If you were then to calculate mortality, you'd need then cancer mortality, for example, here. And then in the site, then I put in where you can get those data. Using those three different data, then you can easily calculate populational attributable fraction. So picking another example from another country. So this is then from a study that we did in France in a larger project, actually, where then we calculated the proportion of cancer that are linked to tobacco that can be then attributable to tobacco smoking in different group of socioeconomic group. So if you're looking into the left-hand side, so in the least deprived group, the proportion of cancer that are related to tobacco smoking in men is less than 60. If you're looking then in the lower or most deprived population, then it's much larger. It is because then in this group, so in the most deprived group, there's a higher proportion of people who are then smokers. You see it in men, so that's in the blue bar, where then you see an increasing proportion of cancer that are related to tobacco smoking, with then decreasing socioeconomic status. And you see that as well in female here. It's at the lower level because then the proportion of smokers among women are a bit lower than what you see among men. After this, then we can start playing with the data. So then we can then start asking the very simple question: if the lowest socioeconomic group would smoke as much as the highest socioeconomic group, how many cancer we can prevent in France? And this is then the first thing that we did. So for example, because then the least deprived still smoke as much as they did, there's no reduction there. But then in the second least deprived group, we can then reduce by almost 2% or to 1%. But then in the highest or the most deprived group, we can almost reduce, I'm not saying 10%, but close to 10%. And that's a lot of cancer sites. So just by trying to target this inequality in smoking, making everybody to be equal, we can already reduce a lot of the inequality in cancer incidence related to tobacco smoking. So that's just one example. Reducing inequality is one way to reduce inequality in cancer, but it's really one way. And then, as Diana already showed, it's only then targeting what's at the closest problem of the whole socioeconomic inequality, where then we really need to think of a higher level of changes. We did then further analysis by trying to look into the future and trying to do different kind of intervention in the different socioeconomic groups. And then if there's nothing done today, the inequality would even grow larger. So there's something that to be done. And then this is one way to do it. But then we also show that reducing the inequality in risk factor is only one small part of the inequality in cancer overall. And then if we were then to really reduce inequality in cancer overall, we need then to take this into a higher level, take this into a national cancer plan, but even higher than cancer plan, because I think socioeconomic inequality is not only a problem for cancer, but it's a problem for the whole system itself that needs to be addressed. So thank you so much for listening. I'll put then a lot of references in the website, and if there's any question, happy then to discuss more on that.
Thank you very much, Isabel, for this nice overview of your work on population attributable fraction. And next we pass to Dr. Ahmedin Jamal, who is a Senior Vice President of the Data Science Department at the American Cancer Society, Atlanta in the US. Dr. Jamal has a broad interest in the area of surveillance and health services research, His work has informed public health policies and served as a catalyst for etiological research. For example, his findings on the positive effect of the Affordable Care Act on cancer care and outcomes have been used to defend the law. And in fact, now he's going to talk about the Affordable Care Act, also known as Obamacare. And please, Ahmedine, the floor is to you when you're ready.
Thanks so much for your kind introduction and for inviting me to give a talk on the effect of the Affordable Care Act on cancer care and outcomes in the US. As most of you may know, the United States is the only high-income country without universal health coverage. And there are two major health insurance in the US. Private health insurance, largely it's employer-based and covers most of the population in the US. And the second major health insurance is public health insurance, specifically Medicaid, which is a federal health insurance program for age under 65 years. It's sort of, you could say, universal health care coverage. And then we have also a Medicaid, which is a joint federal and state health insurance program for the poor under age 65 years. And it's administered by states with variable income threshold for eligibility. But those persons who are under 65 years and who are not poor enough to qualify for Medicare or not rich enough to purchase their own private health insurance, they will be uninsured. And sadly, in 2010, we had about 50 million adults and children under age 65 who are uninsured. So we have heard the importance of access to care from Diana. So in order to make this change, which is to improve the accessibility, affordability, and also the quality of care to all population in the US, the President Obama in 2010 signed the Affordable Care Act. And this, or as Salvatore said, it's called Obamacare. And this law has many provisions and includes dependent coverage expansion, which allows young adults to be insured under their parents' insurance until they turn 26 years old, and also elimination of cost sharing for preventive services recommended by the US Preventive Service Task Force, which includes also cancer screening. And these two provisions were implemented right away after the signing of the law in 2010. Another major provision is expansion of Medicaid to broader groups of low-income adults beginning January 1, 2014. 25 states and the District of Columbia that are shaded in blue implemented or expanded the Medicaid on January 1, 2014. And what I'm going to do in the rest of my talk is just to briefly discuss one or two of our studies on the effects of each of these three provisions of the law on access to care and outcome as examples. So my first example is on the effects of dependent coverage expansion. We used the National Cancer Database, which covers about 70% of incident cancer cases diagnosed in the US. We looked at changes in proportion of early stage, which is stage 1 and 2 cervical cancer, and receipt of fertility sparing treatment before the implementation of dependent coverage expansion, which is 2007 to 2009, and after the implementation of this specific law in 2000 and 2012 in age groups 21 to 25, which qualifies for this provision, versus in those age 26 to 34 who do not, which we are using them as a control. We found that both for early stage diagnosis and fertility sparing treatment after the implementation of the Affordable Care Act, rates, the proportion increased in age 21 to 25 years old, but not in 26 to 35 years old, as you can see from the slide. If you compare the change in proportion in age 26 to 34 to those in age 21 to 25, the proportion increased by nearly 8% for early stage diagnosis and by nearly 13% for fertility sparing treatment. Actually, this was the first study to report on the positive effects of the Affordable Care Act on cancer outcome, and it was widely covered by the major media outlets, including the New York Times. My second example is on the effect of elimination of cost sharing for preventive services. We specifically looked at changes in colorectal and female breast cancer screening rates between 2008, before the implementation of the Act, and 2013, after implementation of the Act, in privately and Medicaid insured adults by income using the National Health Interview Survey. We found that between 2013 and 2018, colorectal cancer screening in age 50 to 75 significantly increased in only low-income adults, but not in middle and high-income adults, which we expected to see, because financial barrier to screening or receipt of any care will be a barrier only in low-income adults. Now, my final examples are on the effects of Medicaid expansion. In a paper published in JCO, we looked at in uninsured rates and early stage diagnosis before the implementation of the Affordable Care Act, which is in 2014, and after the implementation of the expansion medication among adults 18 to 64-year-old newly diagnosed with cancer by area level income in Medicaid expansion states versus in non-expansion states. This slide shows quarterly percent uninsured among patients with cancer age 18 to 64 years by income, by three groups of income in Medicaid expansion states on the left side, in non-expansion states on the right side. So I would like to point out 3 pointers from this slide. First, in both expansion and non-expansion states, there is a large disparity by income. Second, within each income category, there is a similar large disparity between expansion and non-expansion states. But the most important point that I would like to mention in the slide is in the non-expansion states, the percent uninsured in both low income and middle income adults decreased substantially after the implementation of the Affordable Care Act, which started Q4 of 2013. And this led to near elimination of the disparities in percent uninsured between low income and high income cancer patients. But when in contrast, in the non-expansion states, the disparity in percent uninsured in low income and high income cancer patients remain unchanged. We extended this analysis by states in a paper published in JAMA Oncology, and the paper was led by my colleague, Dr. Shisong Han. So we found a very striking disparity in reduction of percent uninsured by the state. Specifically, what was very striking is the difference between expansion and non-expansion neighboring states. For example, Kentucky had expanded Medicaid in January 2014 versus Tennessee, which did not expand Medicaid in 2014. So before the expansion, both Tennessee and Kentucky had almost a 10% uninsured rate. But after the expansion of Medicaid, the percent uninsured in Kentucky declined to almost 2% compared to Tennessee, which remained relatively unchanged. You see a similar pattern for Arkansas versus Mississippi, for Colorado and Utah, and for Oregon and Idaho. So in the Medicaid expansion states, we also found a small shift, but statistically significant, toward this early stage cancer between 2013 shown in blue and 2014 shown in age 1864 years. Specifically for cancer that could be detected early through through screening or clinical manifestation, which includes colorectal cancer, lung cancer, female breast, and melanoma. So in conclusion, as expected, the Affordable Care Act has improved access to care, to cancer prevention, and cancer among non-elderly cancer patients. It has also led to reduced socioeconomic disparity in access to care, specifically in uninsured rates. But still, we have about 33 million males and females under 65 years old who were uninsured in 2019. And still 12 states have yet to expand Medicaid as of November 2020, which are shown in orange color. And of course, we need to continue monitor for the distal effects of the Affordable Care Act, specifically on survival and mortality, which we are working on it. So I would like to thank my colleagues at American Cancer Society, and I thank you for your attention.
Thank you very much, Ahmedine, for this nice overview on the Obamacare and the impact on cancer and cancer inequalities. And it would be nice to see what happens with the Trump administration and with the income administration soon. It would be nice to see in the future. So we have a few questions coming from the chat. The first question is for Diana Sarfati, and we have Sarah from Georgetown University. She's Colombian, and she's asking, as you stated, having complete and accurate data is key to reduce inequalities. I'm curious to know what are the major challenges you have experienced or know of when planning and implementing cancer surveillance in developing countries. And the question is, do cancer registries ever include social factors? If so, which? And actually, this question relates to another question for Isabel, so I'll do them all in once. They relate to collection of data. From Francis Makoka in Kenya, collating data remains a Kenya challenge in sub-Saharan Africa. For instance, in Kenya, data reported to Globocan come from Nairobi and Eldoret cancer registries, representing a very small proportion of the population. For us to measure how social inequalities impact cancer, there is need to collect data from different parts of the country. So these two questions are related. Diana, if you want to start, and eventually later Isabel.
So data collection is definitely an issue, particularly in low and middle income countries. And I should just sort of probably start by saying, in terms of identifying cancer, so getting good cancer registries up and running in low and middle income countries, IAC has been doing work around the world developing cancer registry hubs, and so supporting those regions to develop in that area. My experience, my sort of more hands-on experience has been particularly in the Pacific region. So Pacific, particularly Pacific Island countries, don't have good data collection systems by and large for cancer. And the issues that they face are basically relating to resources, so financial and personnel resources, but also the other issue is competing priorities. So often low and middle income countries have a huge range of competing priorities. So the work is really, that IAC is really leading, is to support those countries to develop the capacity to measure cancer incidence. In terms of whether social factors are included as part of that process, generally speaking, social factors are not measured within cancer registries, but in some cases, those factors can be linked from other data sources, but not so commonly in low and middle income countries. And that's also true for example, for Indigenous populations. Often Indigenous data are very poor, Indigenous identification is very poor, which makes it very difficult to identify and monitor inequalities that are happening for those groups. So that is also work that's going on within countries, both low and middle income countries, but also high income countries, how we can better measure those social factors that underpin cancer. But I'll hand over to Isabel, who may well have things to add to that.
So I'll respond then to the cancer registry data, or data overall. In terms of cancer registry, as Diana said, it is acknowledged and well known that there's a lot of challenges in building up, developing, working with cancer registries. And then the examples that are mentioned here are then from Africa, for example, Kenya, but it is a challenge everywhere. I can even bring up example of challenges of having cancer registries in European countries. So it is not always without difficulties or challenges, but then we also have proven that it is possible, even in the lowest income settings. We can collect data. There are ways to do it. There are initiatives in IARC that are to just support development of cancer registries. Please do come to us. You have our addresses, and then we'll be happy then to work together to develop that further. In terms of the data on socioeconomic status, it is another difficult challenge in higher income countries. Like Diana said, we often actually link those data, not only linking, but we also then use proxies information, for example, the area where a person lives, and then looking into then census data in that areas, for example. But then in lower and middle income countries, there are actually quite a lot of data on collection of such data, and socioeconomic status can be, as mentioned before, identified differently. So some are actually looking into religions, and then probably that's the most important determinant, etc., etc. So it should be looked depending on the context, depending on the infrastructure, but we have proven that it's possible. And then there are ways and strategies to do that.
Yeah, before asking a question to Ahmedine, I spotted another question related to that. It's Tanya from Chile. She says, what do you suggest to convince the authority to improve cancer registries and include socioeconomic variables? I don't know if there is an answer for this, but if you just want to briefly comment, and then I'll pass to you.
Guy, do you want to go first? You're now with the governments, and then I can.
Yeah, well, if it's too complex, we can skip it.
Well, no, I would noted that she was saying that a new law had been passed to support that. So that's great. That, you know, having some legislation to support the collection of data is excellent. And I guess it's like all advocacy really, is just to keep pointing out to those in power that that these data are important, that they do inform policy, and that they are useful to the decision makers. So, you know, that's really the key thing, is to keep pushing the usefulness of the data and identifying where decisions can be strengthened, you know, when data are available.
Working together with a lot of the stakeholders really help as well. And then a lot of times cancer registries data are invisible in the back. Well, then it should be much more visible. And then I think visibility is important as well, reminding, advocating, but working together with different stakeholders, patient group, for example, but governmental as well, helps really a lot.
Thank you very much. A question for Ahmedine. What about Trump government investment and non-investment in cancer prevention and cancer care? About the Trump administration. You're muted, Ahmedine. You're muted.
Sorry about that. Yeah, so if I understand correctly, it's about the budget, right? Is the question. Yeah,
it's not on the budget. Is what kind? I think is yes. I think is meant as economic investment and non-investment in cancer prevention, and yeah, in that sense.
Yeah. So I think the Congress approves. The NSI prepare the budget and submit it to the president and the Congress. And as far as I know, I think there hasn't been a decline in the budget in the Trump administration, but it didn't increase as much as we have seen in the previous administration. But what Trump is known is really about the Affordable Care Act. He wanted to kill that, but he partly succeeded in a way that, because he eliminated the mandate for buying private insurance, but still the major provisions are still there. But yeah, so it didn't increase, the budget didn't increase, the NSI budget didn't increase as much as in the previous administration, but it hasn't really shrunk or declined during his administration. Because it is even if he proposes it, I think he may have, if I remember, he may have proposed a decline, but the Congress said no. Yeah.
Okay, thank you very much, Ahmedine. Another question for Diane is David Conway from Glasgow, Scotland. We know him. Good to see you. Fantastic talk. Thank you. How far do you think social cancer epidemiology, public health should go in advocating for social policies, eradicating child poverty? An example you gave with links to cancer. There seems to be more comfort talking about more downstream smoking, alcohol, diet policy with cancer policies, but less inclined to talk about social and economic policies. Thank you very much. This was David Conway.
Oh, hi, David. Thank you for the question. Yeah, I think it's absolutely part of the role of social epidemiologists and others to advocate for addressing those higher level determinants. I think it's an and situation. I think we do have to focus on those proximal drivers. So we do need to be focusing on specifically on tobacco control, for example, but we do have to think about those higher level determinants, because if we don't address those, ultimately we can only get so far. And the other thing is it hopefully helps people to shift from a kind of this is an individual choice thing, that people are choosing to eat in an unhealthy way, or choosing to smoke more, or choosing, which there is an element of that. Of course, there's always an element of individual choice, but those choices are made in the context that people live, in the social and economic context in which they live, which really impacts on the ability to make those choices and the choices that people make. So we have to be constantly thinking about those upstream drivers. The other thing I'd say is that cancer is quite powerful. It provides powerful stories, and sometimes that can provide really good illustrations to discussions which can sometimes come across as quite dry. So for example, in New Zealand, there's been conversations about healthy homes and trying to make sure that people have access to really healthy homes and not overcrowded homes, for example, and actually thinking about the fact that even that has a link to cancer. People are really surprised by that. It focuses the mind. They think that seems to be incredibly unfair and unjust, and so it strengthens those arguments. So I think we absolutely have a role in that.
Thank you very much. We have Caroline from Canada for Isabel. She's asking, as you noted, disparities in tobacco use have been known for about many decades. So what are the barriers to readdress this problem, which seems soluble?
A lot. Now I'm thinking what Diana just mentioned now is probably one of the main factors. We've been trying to address the proximal factor, the closer factors, which works. But even then, if I think of even higher income countries, I'm not blaming the system, of course. There's a lot of at the moment thoughts of intervention where then it's done. We do it and then we do it for all the population, which works. But then the problem is we know as well that intervention works differently for different subgroups for a lot of the reasons that Diana already mentioned before, contextual factors. So that needs to be taken into account, that those even lower level intervention works. But when that's then done properly, then the next thing that needs to be done is then to pick up the higher level, because without it, inequality would never be behind us.
Thank you. Related to that, for Ahmedine, there is Isabel Portillo. Do you think to finance smoking cessation treatments could reduce inequalities?
Yeah, definitely. I think if you look at in the US, still tobacco accounts for between 28 to 30% of cancer cases in the US, and we know that's most preventable leading cause of cancer deaths in most parts of the world, and it's that also relates to access to care. We wrote actually in our recent paper, what we wrote we looked at really receipt of counseling or treatment for tobacco dependence among cancer survivors, and only actually 8% of cancer survivors who wanted to quit receive both counseling and treatment for tobacco dependence. Definitely, I think having those definitely will help on reducing the burden of tobacco-related cancer in the US. But also another intervention that hasn't been really fully utilized in the US is really tax. We know that excise tax on tobacco is one of the most important intervention for reducing tobacco use. But in some of the states, the disparity in excise tobacco tax by state it's very striking. In New York, you have New York and New Hampshire excise tax per pack is over $4 compared to Missouri, less than 50 cents in most southern states. Yeah, so I do believe that all of this intervention would help.
Thank you very much. We have a very interesting question. It's not addressed to anyone. This is Hélène from Georgia, I think Georgia, US, I guess. What could be the very first steps to tackle the inequality as a junior doctor? I don't know if maybe Diana, you want to start, or if some, yeah, if you have some ideas.
Yeah, no, I think it's a great question, because often, you know, when you're a junior doctor, well, at least my experience of that is you don't feel particularly powerful. You sort of feel like you're at the bottom of the heap. So the first thing I'd say is don't underestimate your power when you're a junior doctor. I think there are two roles that you can play as a junior doctor. The first is an advocacy. So just getting any opportunity that you have. And when I say advocacy, I'm thinking about many elements of that. So advocacy in relation to the sorts of things that we've been talking about, tobacco control, for example, but also advocacy within your own area. So if you're a junior doctor, thinking about the makeup of medical students in your country and whether that reflects the population that you're serving. So are there good policies to ensure that those that are currently underserved can get into medical school and provide care to their communities? Also, when you're thinking about, for example, being involved in research, if you're doing research about inequalities, you shouldn't be doing research on people, you should be doing research with people. So you need to make sure that the research is led by and informed by those who are, again, most impacted by inequalities in order to get findings that are relevant. Just one example of something that a junior doctor in New Zealand did, she actually put together a podcast about her experiences of really, I guess, institutional racism and disparities being experienced by Māori in New Zealand, and that became really popular and really started a public discussion about those issues. So, you know, there are things that you can do.
Thank you very much. We go on with the questions for Isabel. Thank you for the brilliant talks. I have a question about data collection in low-income countries. This is André Vieira from Portugal. Can the digital transformation that is developing full speed now be applied to these countries for cancer prevention?
So there's a lot of promises in the whole data transformation, technology advances and so on. And I think it would change, as we can see now, the webinars are already changing. And I think it would be even changing faster in the future. That said, I also think what the inequalities that we've seen in terms of technology adoption, unfortunately, are also then very socially, very unequal if you compare it in different countries. If you see a lot of these technology advances are being really benefited by higher income countries, we're talking about countries, well, then the lower middle income countries are still then disadvantaged in that sense. So making this equal, reducing the inequity in technological advances would, I can imagine, also help a lot in reducing inequalities. For example, just an easy example of data availability.
Thank you. And now we have Sita Andarini from Indonesia for Dr. Jamal. How to reduce inequalities in cancer prevention, surveillance and control? Will universal health coverage increase cancer prevention and control, not only diagnostic and treatment?
Yes, yeah, definitely. I think a major, actually, barrier to inequality, in my mind, in the US, is really access to care. Because the access to care affects all the cancer continuum, from prevention to early detection, treatment, survivorship care. And as I said earlier, there are over 30 million adults and children under age 65 who are uninsured to date in the US. And I think one way, actually the best way to reduce inequality in the US really to expand access to care, which affects us, as I said, from primary prevention to early detection and treatment. One example that I would like to give is that in a paper published in 2008, which was before the implementation of the Affordable Care Act and widely used by American Cancer Society and other agencies who care about access to care to the disadvantaged population, is that we showed that survival for stage 2 for uninsured stage 2 colorectal cancer patients, their survival. Uninsured patients diagnosed with stage 1 colorectal cancer had worse survival than, insured patients diagnosed with stage 2 colorectal cancer. I think that speaks volume. It's not really, I have that slide in my presentation at the end of it. And this is very striking. This is the power of really access to care. It's not biology, it's not really other socioeconomic status like educational attainment, but it is really it is really whether you have access to primary prevention, early detection, or treatment. And also the Affordable Care Act also show the positive effect of the positive effect of improving access to the low-income population.
Thank you, Medin. Related to this, actually, we have still time for 2-3 questions, maybe a couple of questions. Related to the previous one, we have Dr. Bonjour from France, French medical doctor in public health, and he's asking, or she's asking, something quite important: how to overcome the fact that policies to improve the health of population are mainly used by the higher socioeconomic class, which in no way corrects the social inequalities in health. Meaning that all the intervention, even when they are available for everyone, but is always the higher class that benefits and access to them. So,
yeah,
if you want to,
yeah, okay, I can react. So definitely there is always even in some Scandinavian countries where you have universal care coverage, there is still disparity by income. But that disparity is very, very small compared to the disparity that you have in the US. Okay, so yes, it's not only access to care is not, of course, enough. You have to act also on the knowledge that you have. But still, I think, yes, education or awareness about all the risk factors, the importance of, for example, visiting a doctor regularly impacts, survival, or cancer outcomes. But I still believe that really the major factor is really having access to care.
Thank you, Medin. We still have time for 2 questions, one for Isabel. We have Custodio Muyanga from the US. The speaker discussed major risk factors of cancer and their relationship with social inequalities. What about environmental risk factors, cancer impacts such as air pollution from industrial facilities or from hazardous waste sites? Any stratification of impacts of the type of education, for example, health education programs? Practice environmental exposure to pollution and so on. Yes.
So these are two questions almost. First, and on the environmental risk factors, it's indeed true that we have been focusing a lot on lifestyle risk factors, that's what we call it. But then these inequalities, we see it as well in environmental risk factors. One that you mentioned, for example, air pollution. We tried then to do a similar study as we showed here then in tobacco smoking, but then using air pollution, because then you have actually a lot of data, air data, quality monitoring mechanism, and also then surveillance that's available in a lot of countries that can be used with, to estimate this. And this can be then at the end also then cross-linked by socioeconomic areas in different countries. And then similarly, we see similar inequality because those people who are of the lower socioeconomic or the most disadvantaged group are often living then in areas where then air qualities are not as good as those who are living in the more advantaged population. Another example of a really good example of environmental factors are probably related to occupational factors, and these are then also well studied. Those people who are then working in a lot of occupational conditions or situations where they are then more likely to be exposed to carcinogens are generally also of those of more disadvantaged group. So similarly, if we're looking in environmental or lifestyle factors, we'll see exactly the same inequalities that can be, if I think about it, environmental factors are actually even more amenable to change because that can be really changed at a higher level. A lot of legislations that improve conditions of workers can have a good impact or a big impact in reducing this inequality.
Thank you, Isabel. We have time just for the very last question for Diana. This is Katie Robb from University of Glasgow, UK. Are you aware of any strategies that have been successfully implemented to reduce inequalities between Maori and non-Maori groups?
Thanks for that question. Perhaps I'll use two examples. One, well, the first thing I would say about that is it's absolutely critical to, as I said, in this case, to have Māori leadership and oversight of all activities when we're thinking about addressing inequalities. And I guess that also goes back to a previous question about a high socioeconomic group capture of interventions that somebody brought up before, that we really need to be designing interventions with those who tend to do worst at the forefront of our minds. And interventions need to be designed for those groups first, so that they work best for those groups rather than the groups that least need them. So that's a general comment. But in terms of a particular specific example, in the context of breast cancer screening program, we have very carefully designed treatment sort of procedures and policies and monitoring of those. And what we find where we've got that really tight control of diagnosis and treatment, survival inequalities between Māori and non-Māori disappear because we are keeping such a tight focus on those things and they're being monitored so carefully. So that demonstrates that it's possible to eliminate inequalities in cancer survival, but it takes effort, it takes resource, and it takes focus.
Thank you very much. I'm afraid we are running out of time, yes. And I would like to. We need to close down this nice webinar. I would like to thank all those who joined.